Endoscopic sinus surgery begins with submucosal injections of a vasoconstrictive agent, in this case 1% lidocaine with epinephrine 1 to 100,000, along the lateral nasal wall. The initial injections are placed just anterior to the maxillary line, which represents the junction of the ascending process of the maxilla with the uncinate process. Injections are also placed in the anterior aspect of the middle turbinate. An injection inferiorly along the lateral nasal wall is placed in the root of the inferior turbinate. Supplemental injection can be placed along the posterior aspect of the middle turbinate. This injection infiltrates posteriorly towards the sphenopalatine region. An additional injection is placed here in the posterior aspect of the septum, also anticipating inspection of the sphenoid region with enlargement of the sphenoid ostium. Once nasal packing containing a 4% cocaine solution has been removed, the middle turbinate is infractured to expose the uncinate process. This process is removed with a sickle knife, which incises mucosa, bone, as well as an additional layer of mucosa on the lateral aspect of the uncinate process. Once the incision has been taken superiorly to the region of the frontal recess, it is then continued in an inferior direction towards the maxillary sinus ostium. The uncinate process is reflected in a medial direction to expose the infundibulum. The uncinate process is then grasped along its superior attachment with the Blakesley forceps, which is rotated. Once the uncinate process has been removed, the ethmoid bulla as well as the maxillary ostium are evident. The ethmoid bulla is entered with a small spoon curette to reveal normal appearing mucosa within the ethmoid sinus. This patient underwent sphenoethmoidectomy as an initial step to left endoscopic orbital decompression surgery for Graves' orbitopathy. The ethmoid bulla, mucosa, as well as any septa of anterior ethmoid cells, are grasped with an upbiting Blakesley forceps and removed. The basal lamella is then evident with a small hole shown here. The basal lamella is entered with a small spoon curette at the junction of the vertical and horizontal components. This opening is then enlarged as the vertical portion of the basal lamella is lifted away from the roof, and the posterior ethmoid sinus air cells are exposed. The vertical portion of basal lamella is then grasped with a straight Blakesley forceps and removed. The exposed maxillary ostium is enlarged in an anterior direction with backbiting forceps. Care is taken to only remove thin bone so as not to injure the nasolacrimal duct, which is almost always surrounded by thick bone and lies approximately 1 centimeter anterior to the natural ostium of the maxillary sinus. Once the maxillary sinus ostium has been sufficiently enlarged, the interior of the sinus can be visualized. If we change from a 0 degree to a 30 degree nasal endoscope, The sinus interior with the infraorbital nerve running along the roof of the sinus can be well visualized here. The region of the sphenoid sinus can be identified by reflecting the middle turbinate laterally to expose the superior and supreme turbinates. Between the turbinates in the nasal septum is the sphenoethmoid recess, where the natural ostium of the sphenoid sinus will be found. In anticipation of enlarging this ostium, injections are placed in the superior turbinate as well as the posterior aspect of the nasal septum, which infiltrate in a posterior direction. The frontal recess can be opened for better visualization with a 0-degree endoscope by using a Hayjack forceps to remove the anterior attachment of the middle turbinate to the lateral nasal wall. A right angle spoon curette is placed into the frontal recess up into the frontal ostium. At the top of the screen, shown here, is the anterior ethmoid artery. We see here more posteriorly the remnant of the vertical portion of the basal lamella where it attaches to the ethmoid roof. Some mucosa as well as some residual bone is evident in this region. And this can be removed with the Blakesley forceps. And a remaining posterior ethmoid air cell is opened and removed. The lamina papratia is skeletonized. And again, the natural ostium of the sphenoid sinus can be identified by reflecting the middle, superior, and in this case as well the supreme turbinate in a lateral direction. And the sphenoethmoid recess, we see the natural ostium of the sphenoid sinus. This can be enlarged in an inferior and medial direction if necessary.